Very, very good technique to do. Okay, let's go from there. Just try that one. Gets manipulated. Let me just go over the principle of this with Chris here. You remember when we were doing the gapping of all of the joints now, we have that principle in our minds of where the facet is, that costotransverse facet, as to whether our push should be organized a little bit straight back or whether we direct the spine in the same way that the hand would be coming upwards and kind of forwards a little bit at that angle for these lower ones. So our inclination of the spine would take that into consideration, and we could actually accommodate a slightly upward forward movement, a straight forward movement, and this one, if you look at the spines, you'll see that the transverse process and the facet is slightly on the anterior inferior aspect, which means that we have to push downwards in a way caudally, ventral, and a little medial, because it's sitting there. So that would be the way to push it. Now you'll see in many books, and Stoddard's is one of these, that the neck is locked by rotating this way, and then the joint is moved by taking a grip with the hand like this, and then just pushing down through the first rib angle. The trouble with this, of course, is that in rotating the head this way, the transverse processes go that way, and when we try and move the rib, the transverse processes can just go in the direction of the rib. So Kaltenborn was the first one to work out and to mention that we should be rotating the head back in that way, so that the rib transverse, the transverse process of T1 is held back and stable, and so that when we push forward now, that transverse process can't move because we lock it, as it were, in right rotation to prevent it going into left rotation with the movement of the rib. Now, one of the problems here, of course, is that we know the locking that we should do, which is the rotation side bend. But in having the rotation side bend, we're putting tension on the scalenes. So I think it's probably better in this case to build up the tension by doing the rotation first and then doing a little side bend, which won't be so great, than rather doing side bend first, then rotation, as the scalenes are more likely to be stretched in side bend opposite than if we do rotation. So let us rotate, feel the first thoracic vertebra, put our fingers on the transverse process of that, and let our fingers go a little bit towards T2, and as soon as we kind of arrive at movement at T1, we back off a bit because we don't want it to be too much. Then I go into a I go into a rotation till I get down there, back off a bit. Then I go into side bend and pick up the strain there. Now I've got that joint fairly well stabilized. Now I can change over, put my hand on the head here because I want to support the neck, come into the first rib here, and then the technique will be to ask the patient to softly breathe out, because that will come with the forward and down. Just breathe out. It will also reduce any tension in the scalenes, which are muscles of forced inspiration. Okay, so just gently out, please. And I will do a little thrust forward like that. Now, am I going to use this, or am I going to use that? Use whatever you feel you can engage with. And just in there, or can you do it there? But try and support the head and make sure that there's no force down on the head with your body. It should be kept relatively supported like this. And I think this is a sophisticated technique, which I find probably better. I tend to mobilize this, breathe in a bit, up here a bit, now relax, breathe out, and try and do some sort of post-isometric relaxation stuff, breathe out, and try and follow it down, and then do a little impulse at the end. And I feel that this position is the best, and so I'm only going to show you this, not let us try and do it in 5 positions of side lying and laying on the back. I think that this is the one that Olaf does. It's the one that I've done for a number of years, and I think it's the best one rather than laying them down. But certainly rotating away from the side of the rib, I feel, is essential. If you rotate this way, you'll get more cracks, but they're mostly in the cervical spine. So if you want to impress your patients, do it that way. If you want to know that you've moved the rib, do it that way. Yes?
How does this patient present that has the first rib?
Oh, generally speaking, tenderness in the trapezius. You look at the, and perhaps restricted motion when you do this. When you look perhaps at expiration, because it's held in the inspired position, there's a bit of a reduction there, they can't go down. You look at the first rib space here, or the first rib, you see that it's a bit elevated one side. You gently side bend the head here like this to take the strain off the scalenes, and it stays up rather than goes down. You mustn't do this too much though, because if you do it too much, what happens is that the side bend goes into this and tilts like that, and it looks as though it's corrected the rib, because the whole of this has dropped down. We only want to do just sufficient reduction of tension on the scalenes to allow the rib, if it's being held up by a tight scalene, to settle down. And if it still is, then I would mobilize that downwards. And possibly do a bit of stretching on the scalenes too, because you could kind of imagine, if it's been up for a time, that there might be some chronic tightness there. I'd also review 2 and 3 and 4 in the cervical spine here and see if there's a facilitated segment there. And if there is, we would use our glide manipulation there. So here we are, bang, and here we are, bang, and here we are, stretch, 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 complete treatment. And then we go into our axial extension, then we find all this problem down here. So this patient that thought it was going to be an easy business are going to have to come for at least 2 months. So we're getting more and more, for complete management. Yes?
Did you say side bend down to C2 or T2 and back off, or to T1 and back off?
No, go to involve T1 in the posterior rotation. So we're actually producing a movement of T1. It's got to go backwards and be held backwards. So we'd be actually appreciating movement down to T2. Because we're trying to do that with T1 and hold it there to then direct our caudal, medial, and anterior thrust through the angle of the rib. Okay, let's just do that. And perhaps we could just sit down for 5 minutes and just focus a little bit on the sacroiliac joint, if we could. In your handouts, there is an article by Myron C. Beale called The Sacroiliac Problem, a review of the anatomy, mechanics, and diagnoses. Beale has written quite widely on a number of topics, is osteopathic, as you can see here. I think he comes from East Lansing, Michigan. He's now retired, but this article is actually an extremely well thought out, thought-provoking article on whether we can believe all of the things that we've sort of previously accepted as being true. He challenges concepts of oblique axes and all this. He doesn't challenge them in the way of saying they're wrong. He simply says that there's a difference between what a clinician finds and how they explain it, and what is proven anatomical fact. And sometimes the lines between these get rather hazy. And with teachers, you start to have theories, and before you know where you're going, these have become totally proven facts. Greg Greaves got a little thing in his book from a very famous British rheumatologist called Dudley Hart, who says, what I say once is true, what I say twice is very true, what I say 3 times is very, very true. Okay? And so we have to remember that when we're looking at oblique axes and when we're looking at transverse axes that are involved in respiration, all of the things that have come out and that are out there and people are teaching courses, some of these are quite extraordinary claims. And so in the event of extraordinary claims, I think we need to have extraordinary evidence. Sometimes there is no evidence other than what you seem to feel. And you try and describe what you feel by postulating on what's going on. And that's fine. But we must remember that a lot of this is hypothesis. And I think when Diane gave her thing to you on rotation, she told you this was a hypothesis. This is how she's thinking about this. It's not hard and fast rules. And if you listen to her in a year's time, some of this will be modified, I'm sure. And all of us should be doing this kind of thing, trying to think things through, work it out, come up with an explanation that's like a working hypothesis for us at any given time. I think I showed you this last time, did I? The original things of Mitchell and Fryatt, to show how important this is, and we're not going to spend much time on it. Look at this. The pelvic girdle is the crossroads of the body, the architectural center of the body, the meeting place of the locomotor apparatus, the resting place of the torso, the temple of the reproductive organs, the abode of new life's development, the site of the 2 principal departments of elimination, and last but not least, a place upon which to sit. Okay? And then we look at Fryatt, who's commented on this. Little wonder that the ancient phallic worshippers named the base of the spine the sacred bone. It is the seat of the transverse center of gravity, the keystone of the pelvis, the foundation of the spine. It is closely associated with our greatest abilities and disabilities, with our greatest romances and tragedies, our greatest pleasures and pains. That's obviously been written by a man with such emphasis on this. Okay, that's not the men like that go to groups like me. That's the old kind of macho guy. Okay, but this is kind of one view, and then we come up to the manual therapy group view of this. Greg Greaves' view, and look at the difference here. This is kind of a straightforward, but nothing like, you know, what we saw there. That the joint is a movable weight-bearing, part synovial, part fibrous, and dysfunction includes a hindrance of movement, usually reversible at some point on the limited range of motion, fixation at the limit of range, and these 2 things will be what we will address, irritability, which at times can be severe. It's a very disabling joint, this. Sir Reginald Watson-Jones, who wrote one of the finest sort of treatises on orthopedics and was actually quite adamant against mobilization and manipulation, I must say, but probably that's because his father and people before came from a bone-setting tradition, and I was probably a tendency against what Dad did, okay? But he actually stated with this joint that it can really render a patient to make them totally an invalid. And this was in the times when, generally speaking, orthopedic surgeons felt with the sacroiliac joint it didn't move apart from in pregnancy, and that to get any trauma of the sacroiliac joint, you actually had to be involved in major trauma, like motor vehicle accidents or whatever they called them in those days. All right? But he recognized that you could get a lot of irritability, and he's a very conservative orthopedic surgeon, that this is a very disabling condition. We can get tendency to hypermobility when adjacent structures become stiff. This is the whole business, isn't it, of the pelvis, hip, and lumbar spine, the HPL complex, and that stiffness in one is going to be compensated by movement in another. It's subjected to arthritis and arthrosis. Vleming from the Netherlands has done some very good work on this, and what he now suggests is that these factors that we used to take into consideration, that there looks to be sort of so much arthrosis in the joint that in a male we imagine that this seizes up at 45, now has to be rethought. And what he says is that this is a natural aging of the joint, and that if you look at the joint, not in terms of just bone, but you look in terms of recent specimens, if these recent specimens show very major irregularities, but these irregularities have still got little caps of articular cartilage on them, we could probably still suppose that movement still occurs in that joint. And so I think we've got to rethink, and I've thought this for a long time, you know, men over the age of 50 do get sacroiliac problems, but I think that if you get a male with a sacroiliac problem that's over 50, you scratch your head, you rethink your signs, and you reanalyze, because it's not kind of usual. But certainly, you know, women of 60, men of 50 certainly get problems here, and I don't think that the idea that it arthrodeses is now a valid one, and Vleming has really addressed that issue extremely well. It can get involved in diseases of the adjacent bone, and we can get instability due to ligamentous laxity. That's a nice conservative view of a joint which certainly moves, which gives us resilience, which transfers the weight of the body from the upper limbs to the lower limbs, which transfers movement from the upper trunk down into the legs and vice versa, and that the movement that occurs in this joint is brought about by the effects of gravity and by the effects of movement of the trunk, and if the movement is symmetrical, it will produce a symmetrical movement in the sacroiliac joints, so long as they are symmetrical, which of course we know is not the common thing. They are quite asymmetrical. That if we do a movement to one side or the other, we will get an asymmetric happening in the sacroiliac joint. And the same with the legs. Both legs extended, both legs flexed, will produce a symmetrical movement here. And if we do this and that, we will get an asymmetrical movement. So this is the absorption point of where we transfer weight from legs to trunk and trunk to legs. And we need it moving. And if it's unstable, it's very, very disturbing. Unfortunately, the fusions of this joint are not really all that successful. And so it should only be done when we've got gross instability. Rick Sweeting, who gave a very good lecture on this whole topic, and he's done several, he'd only done about 3 or 4 at the time he delivered the lecture to the IFOMP meeting in Vancouver in 1984. But his protocol was, first of all, to identify the sacroiliac joint by injecting it and making sure that it was now painless because he'd made it numb. And then what is the effect of actually putting on very good stabilization with belts? If that helped but didn't kind of clear it up, then they would do prolotherapy. If the prolotherapy and this helped a bit but didn't finish it, perhaps he would consider doing a fusion of this joint. But this process took about 18 months to decide that this was the only route to take. And out of the patients that he'd seen, I think 3 had done quite well, 1 had been very disappointing for him. But it was a very strict protocol. So this is an interesting joint to treat. Now, in all your previous courses, you know, we've had a look at the muscle energy approach, we've had a look at recognizing instability, we've had a look at stretching on the, stressing the ligaments and all this kind of stuff. And so what we're going to have to do now, unfortunately, because of the time constraints, is to look at about 4 or 5 techniques of manipulation. If we're taking that the joint is locked at a range of motion that it normally does and it's fixed there, or it's fixed somewhere in the middle range of movement and won't move towards normal or in either direction. Okay, so this is what we will have a look at. We'll take 3 scenarios. We'll take a technique that will just free the joint. We'll take a technique that will move it up and down the auricular surface, the vertical auricular surface, and then we'll correct an anterior rotated, a posterior rotated, an upslip and a downslip. And that will give us, with all the other stuff, quite a lot of things that we can do to the sacroiliac joint. We must do the Chicago technique though, mustn't we? That would be very important for us to do the Chicago technique here. All right, let's go to the beds. And I'll just show you 2 or 3 little maneuvers to start with. It's a pity we haven't a little more time, and perhaps we could have even got Chris to kind of address this, but there are several groups in the... lay down, Chris. Yes, please. Facing that way, please. There are several groups of manual therapists in the Netherlands. Chris comes from a kind of an orthodox big group in the Netherlands, but they've amalgamated with a group that belonged to the Utrecht school that was largely followed, I think he was an osteopath, wasn't he, called Van der Bijl. And Van der Bijl developed a whole lot of very gentle techniques in all areas. They call them the eggshell techniques. In other words, you kind of wouldn't break the egg. Now, I was quite interested the last time we had our chief examiners meeting that John Oldham said to me, oh, I'm using quite a lot of what he called functional technique around the sacroiliac. Just very gently sort of coming on and trying to influence, which sort of reminded me very much of the eggshell technique that had been done by the Van der Bijl people. So perhaps it's not necessary to reef around on this joint. On the other hand, you kind of think of what it does and how it absorbs enormous stresses, and you wonder to yourself, well, how much would that do? Particularly as we've got a joint here that is not really under control of muscle directly over it, only muscles that work on the trunk and the legs. So these are sort of things I think we should try and think about from time to time, and perhaps get people like Chris who's seen these do this more often, as to sort of perhaps like a demonstration or something. Now, when we come into looking at the sacroiliac joint, though, from manipulation, here are a number of quite useful techniques. First of all, if we do a technique by just feeling the sacroiliac joint here and just doing a little, what we could call an inflare movement like this. And I'm just looking to see whether there's any movement possible over this leverage at the postero and superior inferior spine. And if it's not moving, and I think there's been a problem there for a long time, I find this very unspecific maneuver quite good. I'll take my on the bed here and let the patient rest in my knees. And all I'm going to do is to come onto the lateral part of the anterior superior iliac spine and very gently just press down like this. This is as close to the eggshell as I get. Okay, so we need an ostrich eggshell for this technique.
The patient is inflared and you're...
No. I'm just saying that this is stiff, and I'm doing what we would call an inflare movement. I'm not saying this is anything to do with that analysis. It's just I'm trying to rock from anterior lateral and just produce a slight springing posteriorly. And it can be done with 2 hands, or you can monitor with the other hand at the back and just have a look at the movement. And it's surprising how much movement this will produce. It's just this gentle motion. Like this. Now, I'd like to show you a technique. I'll do it on the other side, so I can just turn Chris over. Can you face me, please? So the technique is now being done on the right side. And here we fully lock the lumbar spine into a flexion lock with rotation to the right side. So I'll just bring the patient right the way around here into a sort of lock position there. And I'm simply going to take a contact on the posterior aspect of the ilium here. Let me just take the table down just a little. Thank you. I will hold the flexion lock through the spinous process of L5. Then I'll come down onto the sacrum and try and hold all that. And all I'm going to do is to simply pull in an oblique direction down the sacrum like this. And I can do this with a mobilization, or I can do it with an impulse, coming down and trying to just get some motion in the sacroiliac. So neither of these two are particularly specific for a particular rotation. They're meant to try and give us a bit of chance to just get the joint moving. And sometimes I think we do these sort of, not even semi-specific, they are specific for the particular movement, but not for any particular problem. So, I'd like you to do those two techniques first of all, the gentle medial spring from the anterior lateral part of the anterior superior iliac spine, and then just lock the spine, get an oblique axis, look at the bone and just see what you're doing here of pulling down that vertical component of the auricular surface, just down there like that. So it's slightly forward, downward and oblique in its action there like that. Okay, so we're going to sweat a little now for the next half hour. Posterior rotated ilium, which means that we've got to take it into anterior rotation. Fairly simple kind of procedure. I'll get Chris to lay on his stomach, head at this end, please, Chris, facing me. Okay. Now, we could do 5 techniques on this, and actually they're all exactly the same. They look a little different, that is all right? And what we're doing really with all the techniques is trying to take up slack and alter the lever system. That's all we're doing. So we might as well do this as like one of a stage of 5 that you would put perhaps some patients through. First thing that I could look at here is to take the apex of the sacrum and the posterior superior iliac spine like this. I could take up the slack in the posterior superior iliac spine, apex of the sacrum, and then I could do a series of little pushing movements. Is that uncomfortable with my splint there? Okay. Coming through here like that. All right, so that would be the first stage. Some little impulses like this. Theoretically, I should be stabilizing with one, manipulating with the other. In actuality, you tend to have to do it a little bit in this area with both. This is a big joint. This is controlled movement of the total body of the patient. So, you know, our puny little efforts around it sometimes require us to use quite a lot of our force. So I've avoided, as you'll notice, crossing my hands, which was kind of like the old traditional technique. I don't know why we ever used it. It seems just to complicate things, and I can't actually alter my vary my rotation if I've got my hands crossed. And what I can also do is to try to disengage a little bit this ilium by pushing slightly lateral as well. So all of that comes in. Now, what are the problems? I've got a very short lever and a very big joint, all right? When I do this, like this, I might be putting the back into a little hyperextension. We seem to be working it that way. And so what we can do is to take this leg over the edge of the bed. And he just drops it down to the ground and just leaves it there. And this you will see in the little line diagrams that we've got in book number 2. From the German system, all right? And when Chris comes round here, I will lean into Chris, into his anterior superior spines here, to stop him having the feeling that he's dropping over the side of the bed. Now, having got him in this position, this flattens the lumbar spine. It means I can get a little bit more easily onto the apex of the sacrum, posterior superior spine, and I can then do a series of little movements. So we've just accommodated one thing there. Now then, I could be struggling away here and I could think to myself, I could use a slightly longer lever here.